Good afternoon, everybody.
Good afternoon, everybody. Hi, I'm Josh St. Louis. I'm a family doctor up at Greater Lawrence Family Health Center. I completed my fellowship training actually in HIV and viral hepatitis. And so I spent a great deal of my clinical practice thinking about the liver and what it is doing. And my major disclosure is that growing up, I really enjoyed The Simpsons, so I apologize. So two objectives for us today. I would like us to feel a little bit more comfortable with making a diagnosis of cirrhosis. In particular, also thinking about how we assess hepatic synthetic function and hepatic injury and inflammation, which are a little bit two separate concepts. And then I'd also like to help us dispel two common myths in particular about treatments for alcohol use disorder and alcohol withdrawal, in particular around diazepam and naltrexone. So to start off, we need to think a little bit about diagnosis of cirrhosis, and in particular, the idea of synthetic function and hepatic injury. So why is diagnosing cirrhosis so challenging, right? It's the physically largest organ in our bodies. It should be pretty easy for us to know if it works or not, right? Why is this so difficult? And also, why is it so difficult for people to put it in the chart, right? I think every time I'm rounding on our inpatient service with our residents, I lead to all these like confused looks when I sort of look at the labs and I look at the history and I'm like, well, this person's probably cirrhotic, right? And they're like, how do you know that? It's not in the problem list, right? And I'm like, well, it's never in the problem list. So there are a couple of issues, right? There's really, number one, no gold standard to make this diagnosis. And none of us wants to make the diagnosis, right? We all really want to avoid ever saying the word cirrhosis, because then we have to have a conversation with patients about why no one's ever told them this for the past 30 years that they've had cirrhosis, right? And it's been obvious from their charts. The other issue, in particular for hospital-based providers, is that in particular, alcohol-associated hepatitis can sort of muddy the picture, right? Because it can have such a dramatic impact on hepatic synthetic function at a snapshot in time. And cirrhosis is really a much broader sort of time course than that. And if we don't have good outpatient data to support making the diagnosis, it can just be challenging to know how much underlying damage there is to the liver versus how much damage there is at this moment in time. Now, as we talk about treatment options, I'm sort of going to impress to everybody that actually that distinction doesn't matter so much for the acute setting. But overall for the patient, I think it makes quite a bit of difference whether or not you think they have cirrhosis. A couple of years ago, I was lucky enough to co-author an FP Essentials monograph on cirrhosis and hepatic disease with several colleagues. And one of the take-homes we tried to impress to people was that a diagnosis of cirrhosis is never based on a single piece of information. It requires us taking all of the available information into account for a patient. We need to think about their clinical history, right? Do they have a reason to have cirrhosis? Do they have a risk factor, right? They have chronic hepatitis B that's immune active disease that they've had since childhood that's not been treated. Do they have significant alcohol use? Do they have, hemochromatosis, for example? What do their labs show? We're obviously thinking about specific liver tests, right? Elevation of transaminases, depressed synthetic markers. But there are a number of scoring systems we can use, right? FIB4 and APRI, which those of us in primary care, I think, use frequently. And then also proprietary tests, right? So fibrometer is one of the proprietary tests that we can send off. Exam findings. Obviously, if a person has exam findings of decompensated cirrhosis, then it's relatively easy for us to say that they have that diagnosis. Imaging findings, right? Most often with ultrasound, but certainly CT and MR may also make a diagnosis. And then elastography, right? So transient elastography, either by ultrasound or MR, becoming more and more available. We actually have the ability to do ultrasound elastography in our clinic at the point of care. We actually have a mobile device. We can take it on our mobile unit. We can do it for patients who are not in the walls of the clinic. It's the coolest thing. We tricked the Department of Public Health into buying it for us. I suggest you try the same. We discovered that they had several grants expiring on December 31st that they forgot about and didn't know what to do with. And it's a convenient way for them to get rid of several tens of thousands of dollars. So get on that list. And then, of course, hepatic biopsy as well. And, often we sort of think of transient elastography and hepatic biopsy as being quasi gold standards. But again, remember, the liver is a physically large organ, right? And if you are looking at the wrong part of the organ, you may not make the diagnosis. And that's true of both transient elastography and liver biopsy, right? For those of you who do a lot of elastography, you may realize that elastography is basically looking at a similar shape part of tissue of the liver that's just larger than a biopsy specimen. So that's why we can feel really comfortable in it. But if you're looking at a part of the liver that's not particularly bad, you're going to miss the fact that overall it's not doing well. So we need to take all of these things into account. And the other thing we need to think about, right, is that oftentimes people are looking for ways to say that somebody is not cirrhotic, right? Like that is something that clinicians are very interested in doing. And people will sometimes anchor to negative study findings when in fact there have been positive study findings in the past. I once had it out with one of our intensivists when we were co-rounding in the ICU because a patient who had a history of alcohol use disorder had an ultrasound from several years ago that remarked cirrhosis, right? It said, this is diagnostic of cirrhosis. And the patient during this hospital stay had a CT abdomen, which did not remark cirrhosis. And he felt like that ultrasound was abnormally called, right? But we have to remember, we're taking every piece of information into account. These are the times to do good chart dives because you may find that in fact the diagnosis of cirrhosis has been present in the patient's chart for years and nobody has really pulled that all together. So why does this actually matter? Well, it matters quite a bit as we sort of think about two key concepts. One of them is synthetic function and the other is hepatic injury. So when we're thinking about synthetic function, when we sort of have patients in front of us for just a moment, and we're trying to make a treatment decision, we need to think about whether or not their liver is doing the things that a liver is supposed to do, right? Quantifying liver synthetic function is really challenging, right? If you sort of compare this to say renal function, right? You can calculate a percentage of renal function that a person's body is doing at that moment. We have no similar calculations for hepatic function. And the reason is that the liver has over 1,000 documented functions, right? 1,000. It's like actually astonishing the number of things it does, which is why when it stops doing those things, it can be a little bit hard to see in the labs. And in particular, we want to have a sense of whether or not this patient is at their baseline or they're at a particular area of sort of hepatic decompensation. Again, most often in the setting of alcohol-related hepatitis. The lab findings we see when we're thinking about synthetic function, obviously hypoalbuminemia, thrombocytopenia, elevation in PT and INR, as well as total bilirubin. And then certainly as hepatic function decreases further, we'll obviously see further bone marrow suppression with anemia and leukopenia, and then hyponatremia often, which is often a later finding. Looking at these markers helps us to decide which medicines we can use for patients, right? Because we need to know, is your cytochrome system working, right? I think anyone here who's friends with Natalie Stahl knows that there is a fixation on the idea of cytochromy things in the world of addiction medicine, right? Many of our medicines work through the cytochrome systems, and we really have to be expert in thinking about those systems as we decide which medicines we can give. And part of that is knowing whether or not your liver is making them at all, right? Because if you're not metabolizing medicines appropriately, I might need to think about which medicines I give you. Separate from that is this idea of a propensity for hepatic injury or hepatic inflammation, right? So certain medicines are directly hepatotoxic, or if you are not making those cytochromes, they can accumulate toxic metabolites for longer periods of time. One of the things that I think I like to harp on my learners about is thinking about what is normal, right? The normal ALT is not the upper limit of normal that your lab reports. We know from all of the liver societies, EASL and AASLD, that normal ALT should be considered 25 or lower for female identified folks under the age of 65, or 35 or lower for male identified folks or anyone over the age of 65, right? All of our labs reported as like 60 and 70, which is in many cases 1 to 2 times the upper limit of normal. And the other thing we want to think about as we're thinking about these abnormal ALTs in particular is what is their trend? Is it going up? Is it going down? What was the insult that caused it? How long do we expect it to stay high? And has it had an effect on synthetic function as well? Anyone here familiar with liver tox? Hands for liver tox? Liver tox is this fantastic resource that's actually from the NIH. It's funded through the federal government, and it is this extremely large, heavily referenced, basically resource for, is this drug hepatotoxic or not? And it's all FDA-approved medicines, as well as all sorts of different supplements and things. So it's a fantastic resource, and we'll talk a bit about what it tells us for some of our medicines. The other thing we need to think about as we're deciding whether or not to go ahead with giving a medicine that may or may not affect the transaminases is, do we have alternatives that work, right? Sure, this maybe is the best medicine, but is it the only medicine? Probably not. There may be others. So to sort of talk about these ideas, we're going to go through a case. And it's a relatively common case. Your addiction medicine service is consulted for a patient with tremulousness, confusion, and concern for alcohol withdrawal. On chart review, you find that they're a 56-year-old with COPD who's admitted for an exacerbation. They've been given sort of standard medicines for that. They have a relatively complicated past medical history: Gold C COPD, heart failure with reduced ejection fraction, and CAD status post-PCI. On social history, the patient reports 1 beer with dinner on admission, but for the wife, actually more like 3 per meal for the last 35 years. And you go to see the patient, and the patient really looks like shit, as it turns out. Unfortunately, is just not looking well. They have a CWA score of 24, and they have a PAS score of 8. And their labs also really look like hot garbage, right? So you've got an ALT of 250, you have an albumin of 2.8, platelets are 85, INR is up at 1.6, total bilirubin is elevated. And the primary team actually consulted you because your hospital's alcohol withdrawal protocol includes diazepam. And they remember from medical school that you are not supposed to give diazepam to people with hepatic disease. So, poll the audience. What do we give in this situation? I hear lorazepam. Great. Other things? Cerax. Ooh, oxazepam. Love that. I hear diazepam. Oh my goodness. Somebody has to say phenobarb. I know the MGH people are here. Okay, very good, very good. So what do we give? It turns out, as with all things addiction medicine, we actually have guidelines for this, and we actually have data, and just no one ever reads them. How many people here have read the ASAM clinical practice guidelines for alcohol withdrawal? That's not a lot of people for an addiction medicine conference. They're actually quite good. I encourage you to pick them up. And so what do they tell us? They talk to us about the idea that data are all over the place. Studies are garbage. We know that. But we all have brains, and we all went to medical school, and we understand how the liver works, right? So what do we want to do in somebody who is presenting with acute alcohol withdrawal, who looks like the patient I showed you, right? We want a medicine that has a fast onset of action and a long duration of action, right? Because we need to get their symptoms controlled now, or they're going to get intubated and thrown in the ICU, and the ICU is going to do who knows what to them, and they're going to be here forever. Suddenly they're on Precedex. Nobody likes that. And so ASAM talks in particular about these 3 options as really being the only medicines that fit that bill. Medicines that have a fast onset of action and we can manage chronically over a period of time. Diazepam, midazolam, and phenobarbital. And you'll notice that the only one that has an PO option here is actually diazepam, right? So why did all of the 1960s housewives love diazepam so much, apart from the fact that the Sacklers convinced them it was what they should love? It was because it has this incredibly rapid onset of action when given PO, right? Diazepam PO peaks in 15 to 30 minutes, right? PO, it's wild how fast it is, and IV's even faster. This is also, of course, true of midazolam and phenobarbital. I obviously, in case you hadn't noticed, worship at the Church of Diazepam, so that's what I'm mostly going to talk about today. The other thing that's really important for us to consider is that because diazepam's onset is so fast and it peaks so quickly, that we're able to consider dose reduction and close monitoring in patients who we think don't clear it that fast. So in patients who have impaired hepatic synthetic function, you will see within 30 minutes if you gave them too much diazepam, and then you can just reduce the dose, right? The maximum effect of diazepam doesn't accumulate over time. The metabolites can stick around a long time, but they're not going to exceed the maximum that they hit in that first 30 minutes. And honestly, if you have a patient that looks this sick and you're planning to spend fewer than 30 minutes with them when they're acutely ill, you probably need to rethink how you're managing people with acute alcohol withdrawal, right? These patients are sick. We should stay at the bedside until they're well. That being said, in my anecdotal experience, none of them get over-sedated, right? Because patients who are drinking enough regularly to come in the way that this patient did have an exceptional tolerance to things that hit the GABA receptor, right? And so in clinical practice, the chances that you need to decrease these doses is in my experience, not that high. There's this fantastic paper from 2017. Everybody should go read it. I didn't put a fancy QR code because I'm a little bit of a boomer with technology. But its take home here sort of talks about this idea that, you know, people go to lorazepam all the time for acute alcohol withdrawal, and it is not on that chart for a reason, right? Lorazepam's onset, IV, 15 to 30 minutes, peak, often 90 to 120 minutes, right? And so lorazepam leads to dose stacking in a way that diazepam does not, right? Because people are like, oh no, they didn't get better with 4 milligrams of lorazepam. 15 minutes later, I'm going to give them another 4. And then 15 minutes later, I'm going to give them another 4. And then 2 hours later, the patient is like obtunded with like a RAS of -3, right? And now they're going to the ICU because you're like maybe not protecting your airway that well. So we need to remember that in many ways, right, diazepam has this beautiful pharmacokinetic profile that allows us to see in real time the effect of the dose we gave and if we need to give more. And so sort of back to that, I think it is important for us to consider these other options, right? Midazolam is great, easily titrated. In my hospital, I can only give it in the ICU, so that's a little bit of an issue. And then phenobarbital, less data, narrower therapeutic index. Certainly, there are many hospitals with very excellent protocols that have been developed that are obviously safe. We're excited to see more data about them. We've never seen a head-to-head trial comparing phenobarbital monotherapy to benzo monotherapy, right? That has never been done, doesn't exist. I'm salivating at the idea that someone in this room will do that study because I really want to know. I don't know which one is better, but certainly both can work. So what happens with our case? Actually, things go really well. So you decide to treat him with IV diazepam. You give 20 milligrams, Q 15 minutes for 3 doses. The patient's vital signs normalize and he starts to feel much better. And then you put him on 20 milligrams PO every 6 hours for 4 doses and then taper him. That's your hospital's protocol. You did a bit of chart digging. You found that, in fact, the patient has a known diagnosis of compensated cirrhosis due to alcohol as an outpatient. And during this hospitalization, his ALT actually continued to trend up. So he did have a fair amount of acute alcohol-related liver injury, peaked at the 700s during his admission, and it's now down to 260, and his other labs have normalized. So his thrombocytopenia is resolved, his INR has gotten better. Good for you. But unfortunately, this patient is a little bit worried about return to use, and so he would like to start naltrexone right now because that worked really well for him in the past. I think this is a common consult that we all get. So what do we do here? This man has an elevated ALT and he wants to be on naltrexone. Oh, goodness. This is a nice table from one of the JAMA review articles, which has this hilarious not recommended for use in patients with acute hepatitis or hepatic failure. Naltrexone is a treatment for alcohol use disorder. People with alcohol use disorder have liver disease, right? Like, that is what happens, and yet this is the strongest medicine in our armamentarium for treatment of alcohol use disorder. And so we end up in this pickle all the time, and I, as a neurotic type A person, was like, I want to know the evidence, right? Everyone's always told me this. Everybody's always said that this is hepatotoxic. Where does this come from? And so I went to Liver Talks, and it has this really nice thing which says, you know, part of the issue is naltrexone is given to people with a high background of liver disease. We don't really know what this means. And it kind of had this like vague kind of thing. And a lot of it was these caveats of like, but there's a black box warning, but there's a black box warning. So I looked at some of the studies themselves, which this is how they look on Liver Talks. You see it will give you the publication and then right under a one-line summary of the findings related to that medicine, which is really cool. And you see that, in fact, 4,000 people, hepatotoxicity has not emerged as a problem. Like 120%, 12% had ALT elevations, but it was actually just because they had liver disease, right? All of these other things. And then I don't know if anybody saw this article from Journal of Addiction Medicine from just 1 or 2 years ago, showing that in particular, the extended release IM naltrexone was not linked to hepatotoxicity at all in adults with alcohol use disorder and high rates of background liver disease. Like, how is this coming from? And I noticed that all of these articles reference this same article from like 1 million years ago. And I found that, in fact, the FDA black box warning also referenced that article, but I couldn't find the article anywhere. And I got really, really annoyed. And I called one of our reference librarians at Tufts Med School, and I was like, I'm trying to find this article. Can you help me? And I think this is probably the only PDF that exists of this article. As I understand, from 1986 in the Lancet, it is not a study, it is an op-ed of a study of naltrexone 300 milligrams daily for the treatment of bulimia, in which they said, we think that when people use this for alcohol use disorder, they should be worried about hepatotoxicity. This led to an FDA black box warning, which has persisted for my entire life, and shows no signs of stopping. So that being said, I felt pretty emboldened that this is actually a whole load of BS. And so in this case, we talked to the patient, and the patient actually wants to direct to inject with LA naltrexone. You call the drug company, they overnight ship a dose to you to your hospital. They actually have a program that does this. I'm not sure if anyone is aware. They will comp a free dose of Vivitrol for you for an in-hospital initiation of the medicine. Which is super cool. And then you basically say, I think it's going to be fine. I plan to check your LFTs vaguely in a week to make everybody feel better. Talk about other medicines, and then follow up with PCP. So it went well and nothing bad happened. Questions?
I just want to point out that black box was removed for Vivitrol.
Yes, fantastic point. Still on for PO naltrexone, which has also no data of hepatotoxicity.
Thank you.